Okay, picture this. You're in the clinic room. It's a Tuesday afternoon,
Hmm.
and you're sitting with a patient. Let's call her Sarah. She has a confirmed diagnosis of fibromyalgia.
Right.
And you did everything by the book at the first consult. You started her on a guideline concordant dose of a first-line medication,
Mhm.
say 30 milligrams of duloxetine, maybe 75 of pregabalin.
You followed the algorithm perfectly. She's been taking it. She's diligent, so compliance is not the problem here.
Exactly. But she's back for a follow-up 6 weeks later, and the atmosphere in the room is just heavy. She looks at you. You can see the frustration. She says, "Doc, I'm still in so much pain. It's everywhere. This isn't working."
And that's it. That's the classic fibromyalgia plateau. And right there, in that moment, you are at a huge fork in the road clinically.
And the instinct, from 90% of us, I'd guess, is to look at the chart, see she's on a starter dose, and think, well, the max dose is way higher. Let's just double it. The logic is just so seductive. If a little bit of the drug helped a little, or even if it hasn't helped yet, more of it must be the answer.
It's just linear thinking. And in a lot of medicine, think about treating high blood pressure with beta blockers or diabetes with insulin. That logic works. Dose equals response. But we have to be really, really clear from the get-go. In fibromyalgia, that logic is a trap.
A trap. That sounds like a pretty strong word for just, increasing a medication inside its therapeutic window.
It is a trap. I stand by it. Because it completely ignores the specific physiology of nosoplastic pain. We're looking at a mountain of clinical evidence now that suggests when you hit that plateau with this specific group of patients, reaching for the prescription pad is often the wrong move.
So that's our mission today, then. We are going to unpack this whole decision matrix. Dose escalation versus pivoting to these multimodal strategies. Because if that default clinical posture, that instinct to just bump up the milligrams is failing patients, we need to know why.
Precisely. And the goal isn't just to be contrarian for the sake of it. It's about optimizing the patient's entire outcome. It's balancing the potential for relief against the very real risk. We have to dismantle that instinct and see what the new default of care actually is.
All right, let's get into it. Segment 1, the prescriber's instinct versus the clinical reality. So why is that pull to escalate so strong? Besides the obvious that it's just faster to write a new script than explain lifestyle changes.
Well, it feels logical because we're trained that dose response is a fundamental law of pharmacology. You've got a symptom, you've got a molecule that treats it, so more molecules should equal less symptom.
But you're telling me that law is what repealed in fibromyalgia?
It's not totally repealed, but it's, let's say, severely distorted.
So
When you actually look at the data for drugs like pregabalin or duloxetine or milnacipran in this population, you hit the law of diminishing returns incredibly fast.
can you break that down for us? What does that look like?
Sure, so let's think about the NNT, the number needed to treat. When you start pushing doses from the standard range into the high range, so pushing pregabalin up toward 450 or 600 milligrams, the NNT to get a substantial pain relief, which we usually call a 50% reduction, it barely moves. You're just hitting a ceiling.
Why, though? If the drug works on the mechanism, why does it just stop working better at higher doses?
It's likely because of the nature of central sensitization itself. You can't just drown out the noise with more volume because the amplifier, the central nervous system, is the part that's malfunctioning. There's probably some receptor saturation, yeah, but mostly it's that the core mechanism driving the pain doesn't respond to just, simple linear dampening of the signal.
So doubling the dose does not double the relief.
Not even close. But here's the kicker, and this is what every clinician really needs to visualize. While that benefit curve is flattening out, the toxicity curve is not. That line just keeps going straight up.
So the side effects are linear.
Often superlinear. By escalating the dose, you're barely moving the needle on their pain, but you are significantly, and I mean significantly, buying more risk. More sedation, more dizziness, weight gain, brain fog, edema.
Which is ironic because brain fog and fatigue were things patients with fibro were already complaining about.
Exactly. You're trying to treat their pain, but you're actually making their overall functional status worse. You're just shifting that risk-benefit ratio aggressively in the wrong direction.
Okay, so if I'm sitting there with my patient, Sarah, and I accept that bumping her duloxetine up to 120 probably won't fix her pain, but it might make her nauseous.
Yeah.
What am I supposed to do? This gets us to segment 2, I guess. The new default.
And default is the key word here. The clinical guidelines are really explicit about this. When a patient comes back with persistent pain on their initial therapy, the automatic next step should not be more drugs. The default move is to add or intensify non-pharmacologic interventions.
Okay, I hear you on the evidence. I really do. But I can almost feel listeners rolling their eyes right now. Because telling a patient who is in widespread, 8 out of 10 pain to go exercise can feel almost cruel. It's a really hard sell in the clinic. How do we actually bridge that gap?
That is the million-dollar question, isn't it? And if you just say, go to the gym, you will fail. You might even lose that patient's trust. The evidence points to a very specific type of graded activity. We're talking start low, go slow.
So we're not prescribing CrossFit here.
We're not even prescribing exercise in the way people think of it at first. We are prescribing movement. Aerobic activity has the best evidence, so walking, hydrotherapy, a stationary bike. But the key is all in the framing. You have to explain to the patient, this isn't about fitness, it's not about losing weight, this is a prescription for their nervous system.
Like a desensitization protocol.
Exactly that. You tell them, your nervous system is hypersensitive right now. We need to slowly, gently expose it to movement to teach it that movement is safe again. And that is a very, very different conversation from, you need to get in shape.
That makes a lot of sense. It makes the patient an active participant in retraining their own brain. Okay, what about the other big pillar in this new default CBT, cognitive behavioral therapy?
Right, and again, framing is absolutely everything.
Because when patients hear CBT or therapy, they immediately think we're saying the pain is all in their head.
And we have to get out ahead of that. You have to say explicitly, the pain is 100% real. But the way your brain is processing that pain signal is deeply connected to things like stress and emotion. The literature shows that CBT and fibromyalgia isn't about curing the pain signal source, it's about targeting the catastrophizing loop.
The loop where they feel the pain, they panic about the pain, and that panic just amplifies the sensation of pain.
Correct. It helps the patient decouple the sensation of pain from the suffering that's associated with it. The data shows that while pain scores might drop only modestly with CBT, their functional disability scores drop significantly. They might hurt the same amount, technically, but they can do twice as much because they aren't paralyzed by the fear of it.
So the takeaway for the clinician is to feel reasonably confident, just saying, look, I'm not going to change your pill dosage today. Instead, we're going to start you on a structured walking program or get you a referral for CBT.
Yes, that should not feel like doing nothing. That is active, aggressive, evidence-based management. We have moderate to high confidence these interventions improve quality of life and function, whereas we have very low confidence that just upping the dose of a medication does the same.
However, and this is where the whole art of medicine thing comes in,
Yeah.
we can't just have a blanket rule for every single patient. Medicine is messy. So segment 3 has to be about when we deviate from this default.
Right. Guidelines are guardrails, they're not handcuffs. And there are very specific scenarios where your plan has to adapt to the patient sitting in front of you.
Okay, let's run through them. Scenario A. The patient is already having side effects on the current lower dose.
This one's a hard stop, a total non-starter. If Sarah comes back and says, my pain is the same, but now I'm so dizzy I can't focus at work, you absolutely do not escalate. In fact, you should probably be talking about a taper or even a switch.
Tapering sounds risky when they're in pain.
It can be, but keeping them on a drug that is actively causing toxicity with no benefit is just worse medicine. In that situation, your only move for intensification is non-pharma, period.
Okay, good. Scenario B, patient preference. We see this a lot, right?
Okay.
Patients who just hate the idea of pill burden.
This is huge for adherence. You get patients who feel like they're just taking too much chemistry. If you try to push a higher dose on them, what happens? They might just stop taking it altogether. So if a patient has a strong preference for a natural or behavioral approach, you lean into that. You lead with the non-pharma options to get their buy-in.
Because the best treatment is the one the patient will actually do.
Exactly right.
Now, scenario C is the really tricky one. Accessibility barriers. I mean, I work with clinicians in rural areas where the nearest CBT-trained therapist is a 3-hour drive away, and there is no community pool for balneotherapy.
And that's the reality check. It's all well and good for us to sit here and say, refer for CBT, but if that resource just doesn't exist for your patient, you're stuck.
So in that specific case where non-drug treatments just are not an option.
That is the exception. That is the one time where a cautious medication dose escalation can be considered a reasonable path. But, and this is a massive caveat, you have to do it with your eyes wide open, you acknowledge the limited evidence, you acknowledge the potential harms, and you monitor that patient like a hawk.
So it's a break glass in case of emergency situation, not the standard operating procedure.
Correct. And you set clear expectations. You tell the patient, we're going to try a higher dose because we don't have access to these other therapies right now. But if we don't see a significant improvement in 4 weeks, we are coming right back down. Don't let them just languish on a high dose that isn't working for them.
I want to pivot now to segment 4, because patients don't just walk in with fibromyalgia stamped on them. They come with complex histories. Let's talk phenotypes,
Right.
and specifically the psychological comorbidities.
Yeah, this is a very, very common presentation. You have a patient with widespread pain, but they also have significant diagnosed anxiety or depression.
Which is incredibly common with any chronic pain condition. It's a bidirectional cycle.
It is. Now, for this patient, you might think, oh, perfect, I'll just increase the SNRI like duloxetine because that treats depression too. And while, yeah, that's true pharmacologically, the recommendation is still to prioritize the psychological non-pharmacologic therapies.
So for this group, CBT and mindfulness aren't just nice to have, they are the priority intervention.
Absolutely, because escalating the med might numb the anxiety a little bit, but it doesn't touch the maladaptive thought patterns or the coping mechanisms. Addressing the comorbidity through behavioral health is often the key that unlocks the pain relief. You treat the depression, and the pain threshold itself often improves.
Okay, what about the opposite end of the spectrum? The stable but suffering patient. They're on the meds, they have zero side effects, iron stomach, totally fine, but they still hurt. The temptation here has to be, will they tolerate it, so why not just blast the dose?
That is the tolerance trap, and it's so easy to fall into. Just because they can tolerate a higher dose does not mean it will do them any good. Remember the diminishing returns. That physiology doesn't change just because the patient has a strong liver.
So tolerance is not a justification for escalation.
Never. The recommendation stands firm. Do not increase the dose just because there's room in the toxicity profile. The better choice is still to add the non-pharmacologic interventions. You're looking for efficacy, not just the maximum tolerated dose.
I love that. Tolerance is not equal efficacy. Okay, let's move into our last big section, segment 5. We've talked about what to do. Let's talk about what not to do, the pitfalls. Can we do this rapid fire, but you explain the why behind each error?
Let's do it.
Pitfall number 1, the assumption of efficacy.
This is assuming that just because you prescribed more, the patient will get better. Don't conflate doing more with getting results. The evidence just doesn't support a linear dose-response relationship in chronic fibromyalgia pain.
Pitfall 2, monotherapy reliance.
The magic bullet fallacy. Relying only on medications limits the overall benefit. You're trying to fight a complex multifactorial condition. It's biological, psychological, social, with a single biological tool. It's just not enough.
Pitfall 3, misapplying data. This feels like a big one.
It is. This is the acute pain fallacy. Do not apply evidence from acute pain management to persistent fibromyalgia.
Can you just expand on that for a second? I think we all do that subconsciously.
Sure. In acute pain, say a post-op knee, the pain is driven by peripheral nociception. You hit that with opioids or high-dose NSAIDs, you dampen that signal. But fibro is nociplastic. The volume knob is broken in the brain, not in the knee.
So treating it like acute pain is trying to fix a software problem with hardware tools.
Perfect analogy. So when clinicians apply that acute pain logic, it still hurts, so I need a stronger blockade, they fail. That's why you see these patients on huge stacks of gabapentinoids and opioids, and they're still in 10 out of 10 pain. The mechanism maintaining the pain just doesn't respond to that kind of suppression.
Okay, pitfall 4, extrapolation.
Don't look at a study for, say, diabetic neuropathy and assume it applies here. Just because high-dose pregabalin works for nerve damage doesn't mean it works for nociplastic pain. The pharmacodynamics don't just translate across these different disease states.
And finally, expectation management.
This is huge for both you and the patient. Do not expect rapid or massive functional improvements just from increasing a medication dose. If you promise the patient, we'll double this and you'll feel great, you're setting everyone up for failure. You have to preach incremental gains and management, not cure.
It sounds like the theme here is just a deep humility about what medications can actually do in this condition.
It is. It's accepting that meds are a scaffold, not the entire building. They might provide a baseline, hopefully, to take the edge off so the patient can then do the real work, the exercise, the CBT, the sleep hygiene.
So let's bring it all home. If we had to summarize the clinical algorithm for a listener who's walking into their clinic tomorrow.
The core algorithm is this. In an adult patient with persistent fibromyalgia pain who is already on their initial pharmacotherapy, your priority, your plan A, is to add or intensify non-pharmacologic interventions.
And Plan B.
Plan B, which is dose escalation, is reserved strictly for cases where there are real, insurmountable access issues to other therapies or very specific patient preferences. And even then, it is done cautiously, with close monitoring, and frankly, without the expectation of a miracle.
It's a disciplined approach. It really resists that urge for the quick fix.
It forces us to be better doctors, honestly. It forces us to look at the whole patient.
You mentioned something earlier when we were prepping for this about how this changes the very definition of treatment.
Yeah, I think we should probably leave the listener with this thought. In medicine, we usually define intensifying treatment as increasing the dosage. We think vertically, more milligrams, a higher concentration, stacking on more drugs.
Right, just turning the volume knob up.
But if medication escalation offers inconsistent benefits and predictable harms, which is what the data says it does, then maybe we need to fundamentally redefine intensifying treatment to mean broadening the approach.
So a horizontal intensification.
Exactly. Intensification should mean adding a new modality, bringing in the exercise physiologist, adding the psychologist, not just upping the count on the pill that's already in the bottle. A wider base of support is always going to be stronger than a single tall pillar. When you have a patient who is suffering, doing more for them means giving them more tools, not just more chemistry.
That is a really powerful shift in perspective. It takes the pressure off the prescription pad and puts the focus back on truly comprehensive care.
And ultimately, that's what gets patients like Sarah back to actually living their lives.